right, we can probably go ahead and get started now. Hello, everybody. Good afternoon. My name is Andrew Ketterer. I'm from Beth Israel Deaconess Medical Center in Boston, and joining me is...
I'm Jahan Fahimi. I'm coming from UCSF.
And we are here to talk to you about what your residents need to know about firearms. Now, before we get started, we have no conflicts of interest, either financial or otherwise. If you're offering, please meet us after the talk. We're going to address this topic in largely four general categories. So first, we're going to talk about, of course, the epidemiology of firearms injury. We're going to move on to discuss some of the basics of firearms themselves and kind of standardize the terminology that we all use when we discuss them. We're going to talk about some aspects of cultural competency that all of us as physicians and as advocates should be aware of, and we're going to wrap it up talking about context of injury and specific example curricula addressing those particular contexts. So what we're not going to do today is get into a largely political discussion. I think it's pretty difficult to separate this topic from the politics surrounding it, and similarly the strong feelings that are engendered by those politics. But frequently those type of discussions do tend to kind of get in the way of themselves and impede our ability to, I think, get us all to the point that we want to get to, which is namely to reduce the number of bullet holes in human beings in this country. So with that in mind, a brief reminder of kind of what we're dealing with here. I think most of us are pretty familiar with the impact of firearms injury and death on individuals in this country. These data are from the CDC, and in 2020 there were more than 45,000 deaths due to related to firearm injury. That represents an uptick from the preceding years of 30 to 35,000 every year over the preceding 10 years or so. And you know, a lot of these patients, both anecdotally speaking and also when you look at the large data, are male. The reasons for that I hesitate to speculate about, given the risk of self-incrimination, but I think that kind of bears out with a lot of what we see. And I think most importantly is the non-fatal injuries that we encounter, because these are the people who are likely to become our patients. One thing I want to highlight is that nearly 2 in 10 of the non-fatal injuries that were seen in 2020 were from unintentional injury. That represents an uptick from previous years, which largely relates to a lot of new firearms ownership, which we'll get into in just a little bit.
So we'll talk a little bit about kind of the epidemiology when we're thinking about how this breaks down in terms of people using firearms to injure themselves versus injuring others. And it's starting to look more like a 50-50 split. If we went back 3-5 years, it would really be more of a 2/3, 1/3 split, right? Firearms are more commonly used to kill oneself than it is used to kill someone else. It's not to say that firearms aren't used to injure other people, because if you look at assaults, non-fatal assaults, the homicide and assault numbers are significantly higher. But when we're talking about deaths specifically, more firearm deaths have a suicide mechanism than a homicide mechanism. And so, but what we're seeing in 2020 is that these numbers are, it's getting a little closer to a 50-50 split. There are still a small subset of patients who have accidental injuries, legal intervention or officer-involved shooting, or otherwise unclassified. And I think it's helpful to put this into context of other diseases that we think about in the healthcare domain, right? So this is 2020 data. Obviously, COVID is sort of a big number up here, 350,000 deaths. But then when we look at other diseases that are kind of in the same ballpark as firearms, this is kind of striking to me, right? There are NIH institutes related that are dedicated to alcohol and alcohol use disorder. I mean, think about the number of times you've gotten a lactate of 2.1 and you get a pop-up on your screen, right? Because the Surviving Sepsis campaign and our approach to billions and billions of dollars that we've spent on trying to reduce sepsis mortality. Or if we think about motor vehicle accidents, right? And what that requires in order to drive. You need a license, you need to have insurance, the roads are safer, the vehicles themselves are safer. And actually, over the last few years, what we've seen is that the number of motor vehicle fatalities has dropped, whereas firearm fatalities have risen. And it used to be that this was above the firearms, and that those lines have now crossed. And so, why are we seeing this? This is from the CDC, specifically trying to kind of make sense of some of the more recent data. And they've really put this squarely in the camp of systemic inequity, structural racism that are really limiting opportunities for populations very differentially. And that, widening racial and ethnic discrepancies and health disparities are probably driving some of this. And particularly in the backdrop of the COVID-19 pandemic, there's been a substantial increase in the number of homicides related to firearms, predominantly in African American communities, and notable increases in firearm suicide rates, predominantly in the Asian Pacific Islander groups. And this just seems to have worsened the health outcomes that we see for racial, ethnic, and other group disparities.
All of this is in the background, as I mentioned earlier, of basically increased numbers of firearms out there. The specific numbers themselves are taken with a little bit of a grain of salt, because tracking the absolute number of firearms that are newly acquired or that are out there is notoriously difficult. But the trends that we're seeing are pretty clear. First of all, the total number of firearms that are acquired in blue have gone up. You do see these periodic spikes pretty much every year, but with a much more protracted one existing around the COVID-19 pandemic. That was driven largely, though certainly not exclusively, by increased acquisition of handguns, both among previously or experienced firearms owners and also among new firearm owners, for a large number of reasons that were pretty extensively documented in the popular press. There were an increased number of long gun acquisitions. We'll talk about the differences between those two things in just a bit, but really a lot of what we're seeing here is driven by increased handgun acquisition. So all of this taken into account, right, we know the impact that firearm injury and death does have. It's helpful to discuss, when I talk to residents about firearms injury, it's helpful to sort of standardize the language that we're using. I mentioned handguns and long guns to start. Is this a handgun or a long gun? Raise your hand if you think it's a handgun. Excellent, A+. It's not a long gun, this is a handgun. Handguns generally refer to things like pistols or revolvers, whereas long guns classically refer to like a rifle, for example, or a shotgun, though certainly not exclusively. A lot of us are familiar with the general terminology of firearms themselves, the muzzle being the dangerous end, the trigger being the thing that you pull to make it the dangerous end. For semi-automatic handguns, which we'll talk about in a little bit, there's the magazine, which is generally stored in the grip, which is where you hold the gun. Something that causes certainly a lot of confusions, both among learners that I discuss this topic with, but also I think among people inexperienced with firearms themselves, the concept of a safety. And most of us think of a firearm safety as being like a switch on the side of the gun that you use to turn the gun on or off. That's true sometimes. It's not true for this particular handgun. This is a Glock handgun, which famously Glock models have a so-called trigger safety, which is like a second trigger in the middle of the trigger that you actually use to fire the weapon that you have to pull in order for the actual firing mechanism to be activated. Why that's important is that means this gun can neither be turned on nor off. If there is a bullet in the chamber and you pull the trigger safety, that gun can be fired. You cannot make that otherwise by messing with the gun itself. And that becomes important when you're talking to a patient about, say, safe firearm storage, right? If you're talking to the patient about, okay, make sure the safety is on at all times, well, that might not be relevant if they have this style of weapon, right? And so it might be, if they have small children in the house, for example, and you're trying to improve safety at home, having that information ready to hand, understanding what firearm differences exist out there can be helpful in discussing this with patients. Similarly, when we think about bullets, I think most of us think about this entire thing. The bullet technically is only the projectile, number 3, that actually gets projected out of the firearm itself, and everything behind here essentially contains propellant, an explosive material that projects the bullet out of the gun. On that same note, this causes a lot of confusion both in the popular press and in discussions with patients and the firearms community and advocating for policy. Concepts like semi-automatic versus automatic tend to cause a lot of confusion. Raise your hand if you think this is a semi-automatic weapon. Great. Raise your hand if you think this is an automatic weapon. Great. A+ once again. So this is semi-automatic. Essentially what that means is that a single trigger pull will fire the gun once. And then it automatically reloads. What's happening in this particular model is that the explosive force of the propellant drives the slide backwards, and there's a spring mechanism in the magazine which drives another bullet up into the chamber and readies the gun to be fired again. It is not accurate to say that this is an automatic weapon, because automatic weapons tend to be more for military use, where you pull the trigger and you can hold it down and more bullets can be fired from a gun with just a single trigger pull. a lot of the main context of why this causes some confusion is discussions of like assault weapons or military style weapons. And certainly I think when I say, or when anybody says the term assault weapon, a lot of us have a sort of visual, like a mental model for what that actually means. But it's a little bit like describing a rash as maculopapular, right? Like, yeah, I got an idea of kind of what you're talking about, but it doesn't actually refer to anything specific. Some people do circumvent this by talking about military-style weapons, which again, like we all have a general idea of what a military-style rifle might be, but specifically that's going to refer to something more like an SKS or an AK-47, a rifle that was designed for military purposes, as opposed to something like a semi-automatic rifle that might not have originally been designed that way. The reason this becomes important is in contexts of policy discussions, or if you are having firearm safety discussions with individual patients, especially if they are strong advocates within the firearm safety community, a lot of people's brains turn off when you use these types of terms and when you use them incorrectly, because the assumption becomes automatically that you, as the person having the discussion, don't know what you're talking about. So it's helpful that everybody's on the same page with the terminology.
And so on that note, you know, this is a great paper. I recommend people check this out. And what it really does is it frames the conversation in terms of what is it that you, as the provider, need to kind of understand when engaging with patients. There's actually been studies that show that as a physician, you're, in many cases, not deemed to be like a reliable counselor when it comes to preventing firearm injury, depending on, you know, who the patient is and how they might view you, right? Are you coming at them trying to speak to them about firearms from a place of ignorance and saying, you know, guns are bad, versus coming to them with some sense of cultural competence that includes knowing the firearm anatomy. It also includes understanding gun culture and why people own firearms, you know, the history of firearms in their family, et cetera, and what may or may not be acceptable to them in terms of mitigation of risk, right? And so I think that, you know, it's sort of an important piece. We have gotten good at doing the cultural competence for a lot of other, you know, phenomenon, right? We think about like the opioid epidemic. We've gotten better at understanding why patients use opioids and how their use disorder has come to be, and what may or may not be acceptable to them in terms of, you know, medication-assisted therapies or abstinence, et cetera. We kind of need to get to the same place when it comes to firearms. So we're going to talk a little bit about the different sort of contexts of firearm injury. We've been kind of talking about this as though firearm injury is just one homogeneous concept, and it clearly is not. There are some general cross-cutting themes that we should be aware of that, you know, refer across all the different contexts of injury. But, you know, fundamentally, peer violence, or otherwise known as youth violence or community violence, may be very different than intimate partner violence, which is obviously very different than, you know, mass violence, though there may be a lot of overlap, which is different from suicide and unintentional injury. And so I think it's helpful to start thinking about these within these different contexts. And so actually a project that Andrew and I worked on together was to come up with a sort of expert consensus of how we can take those different contexts of injury, think about them within different educational domains, and develop some curriculum, or at least some learning objectives that you all can take back and put into your curriculum, right? We recognize that curriculum, there's not a lot of space, right? You can't create new content and find space for it. But I'm willing to bet that most educational programs, whether it's a school of medicine or nursing or a residency program, et cetera, have some amount of content that can have some of these concepts and these learning objectives kind of spiraled into them. And so I really recommend, if you're interested, to take down that QR code. You'll see there's a list of 51 educational priorities, learning objectives that are broken down by concept levels within the different contexts that you can sort of use as a potpourri to say, hey, this might be interesting. We should probably, you know, incorporate this in our teaching. Or maybe you pick and choose one or two that can be done and taught at the bedside. The group that came up with this expert consensus is across all different specialties, not just emergency medicine. It also includes nursing. It also includes public health researchers, and as well as the AAMC. And this is a little bit of a kind of a matrix that we thought about as we developed those. So again, we have the context of injury across the top there. I've also added here legal intervention, again, officer-involved shootings or police shootings. And then you can kind of think a little bit about medical management. Most people in this room probably feel that most comfortable with that part of it. Then there's the mental and psychological care of patients, which obviously, if you think about it, is going to be very different for someone at risk of self-harm versus, say, accidental injury. Risk assessment and screening, again, very, very different. If you're screening for intimate partner violence, we actually have some really, really good tools that one can use to sort of assess the risk to an individual. But we don't really have a good screening process when it comes to, say, identifying someone who's at risk of perpetuating some sort of mass violence, right? You hear in the news, it's all about mental health. Well, sure, but mental health is a ubiquitous problem. It's, not everybody is taking arms and perpetuating some sort of mass shooting. So, how can you reasonably do risk assessment and screening? And let's say you can do risk assessment and screening, how are you going to do the prevention piece? We also really thought about advocacy as well as legal requirements. I think that there's a certain amount of moral authority that we need to start, using when we're speaking with patients, helping craft policies, educating the public. Again, done within the context of cultural competency, and then recognizing that there are some legal requirements as a mandated reporter, et cetera, as well as laws on the books that like risk protection orders that we should be aware of, because our patients may need to have some of those laws used in order to keep them safe.
So let's wrap it up with a couple of examples of some projects and resources that are out there. So to start with, as a sort of general approach to teaching about firearms violence and firearms injury reduction, one particularly good example of some things people are doing out there is the Bullet Points Project. This is operated by a group out of the University of California, Davis. And they really have a lot of resources. It's a free available online database which covers a lot of in-print and video-oriented teaching materials. They have a podcast series associated with it. There is a CME course that you can engage with as well if this is an area that you're interested in personally learning more about to a much more in-depth degree. But they also have a number of resources for how to integrate this into clinical scenarios. Jahan mentioned that this topic is relevant to basically every other aspect of medicine. When we think about women's health, we think about intimate partner violence, we think about trauma-informed care, we think about a lot of contexts that are relevant to the risk for firearm injuries. Similarly, in a psychiatry curriculum or anything addressing mental health, talking about suicide and addressing firearm injury risk in a suicidal context is critically important, and all of these teaching examples can be and should be, to our mind, integrated into existing curricula. The mental approach or the cognitive approach that this group advocates for is the so-called 3A's: approach, assess, and act. And largely what that means is that, so with the approach, that's sort of coming at the problem with the understanding that the person you're speaking to, or the patient that you're counseling, or the group that you're advocating to or for, might not have the same cognitive, emotional, social background that you are coming at it with. And you need to approach that with a certain degree of cultural humility, as we already discussed. When you take that into account, then you need to assess, okay, here's this patient that I'm caring for in the emergency department. What are the actual risk factors that I'm dealing with, right? Like, does this person truly have access to firearms as an outpatient? And as such, should I be engaging with, say, my psychiatric resources if I feel that this person is at risk for suicidality? With both of those in mind, then this group advocates for then tailoring what your action is going to be, what your intervention is going to be to the specific risk and the social context that the patient finds himself in. That gets everything from counseling on safe storage techniques to engaging with some of these like civil protective orders, so-called red flag laws or extreme risk protection orders, which certainly don't exist everywhere, but do exist in many states. I will note that being a product of the University of California, Davis, a lot of the information here is specific to California, but a lot of it is also very generalizable to much of the rest of the country. And I definitely recommend this as a resource for examples to integrate in your teaching. Another great example, I mentioned suicidality as being a particularly poignant spot where we could integrate increased teaching for firearms injury reduction. This is a product that, again, I have a QR code to it, was produced by the Department of Veterans Affairs in association with the American Foundation for Suicide Prevention and the National Shooting Sports Foundation. And this is an informational pamphlet that describes safe storage techniques, what to do if you are concerned about your own mental health, and has a whole gradation of examples of things that you can do to increase your safety at home. In addition to talking about suicide injury prevention, it addresses, okay, if you have, say, an elderly relative living with you who has dementia, for example, these are some steps that we recommend that you take in order to reduce the risk for unintentional injury. Similarly, if you have children, small children at home who might be at risk for unintentional injury in the context of firearms ownership. So it's a great informational pamphlet for patients. It's freely available online. It can be printed out if you want to, include it in your discharge instructions for a patient that you've taken care of in the ER. It's also a great educational tool for teaching about all of this in the context of the risk factors that we mentioned for both residents and medical students.
So where are we going to land this plane? I think it's clear that few physicians receive the kind of training that we think is necessary to make us competent in addressing the firearm injury epidemic really at the bedside. We know that there are blueprints for how to approach firearm injury risk with, in other diseases that we have become quite good at counseling patients on, and that some of those, like, let's say, alcohol use or substance use, for example, are interrelated with firearm injury. And so I think, we can go that one step further, where if you're going to speak to someone about, let's say, their excessive alcohol use, for example, go one step further and count and screen to see if there are firearms in the home, and understand that the overlap between, say, alcohol use disorder and unsafe firearm ownership can result in injury and death. And then education on firearm injury prevention really can and should be integrated into existing curricula, and like we highlighted, the work that we've done to come up with learning objectives that really should make this hopefully a little bit easier to find areas where some of this content can be delivered to our learners. And so with that, happy to take any last few questions, and then we'll wrap up.
Yeah, there are a number of projects that are ongoing. The punchline is that nobody has any definitive conclusions about the effectiveness of those interventions. A lot of that has to do with the difficulty of truly following up with a lot of these cases and a lot of these patients. But also a lot of it has to do with the fact that people own firearms for different reasons, right? Certainly, we know that your risk for suicide, your risk for unintentional injury goes down if you store your weapon locked and separately locked from the ammunition, and you store your weapon unloaded. Doesn't make a lot of sense if you own a weapon for personal protection, right? And there's no conclusive way that anybody's really been able to parse those specific populations apart from one another to tease out, okay, what are the actual effects of the interventions that I'm staging?
Yeah, I think it's hard, because you really want those discharge instructions or the conversation with the patient, better yet, to be really specific to that individual, situation. And so I find that discharge instructions oftentimes, unless it's very concrete, like, here's where you can go get a free gun lock, and you should start using it. Short of that, every case is so different. We've sort of talked about the heterogeneity of all these different contexts. It's hard to come up with one set of discharge instructions that will encompass all of them.
A lot of police departments do the same thing too, so it's worth being aware of kind of what resources are available in your individual community. Yeah, so the question was, are there any specific tips for patients who do own firearms for personal protection purposes. And there isn't a lot out there that's evidence-based as being an intervention that can be staged for safe storage for people who own a gun for that specific reason. I think knowing what I do about what is out there, that probably approaching the patient with, okay, can we talk about your actual risk, right? Like if you're somebody who lives in an area with a large amount of peer violence, for example, and you yourself you perceive yourself as being at risk for that, that's obviously going to be a very different risk calculation than someone who, say, lives in rural Kansas, who, yes, maybe they own it for self-protection, but their true risk is probably not anywhere nearly as high as the first patient type that I mentioned.
Bullet points is a great resource for exactly what you're asking of, like, what are some tips and tricks of, like, terminology I could use with the patient at the bedside. And one analogous sort of situation is, like, how would you talk to, let's say, a good example is like someone with cognitive decline, early cognitive decline, who still drives. You know, like, really, there's no, like, black and white, like, you got to get rid of your guns. It's sort of like, can we think about transferring your guns to a loved one? You don't have to forfeit them. Can we think about, you know, how over time this issue could get worse? So there's a lot of that built into the bullet points modules that I think helps you kind of think about how you would, what language you might use at the bedside for someone at risk, given the context.
Yeah, so the question was application of screening tools and what do you need to keep in mind for perceptions of bias with patients with whom you might be engaging screening tools with. Am I understanding that correctly? Okay. So again, to take suicidality as an example, I think the evidence shows that screening patients who present for suicidality should include screening for firearms presence, because we know that firearms access, not just ownership, but access, is an independent predictor of successful suicide. When it comes to peer-on-peer violence, for example, I think there's a lot of evidence to show that someone who comes in with a non-fatal firearm injury, certainly engaging with them about, okay, how did this happen? Can we talk about how to reduce the risk that you're going to come back to the ER with a worse injury, or not come back to the ER at all because you die because of a firearm injury? I think there is a good amount of evidence that that can be an effective approach, but you're absolutely right that you don't want to assume why someone owns a gun or why they sustained a firearm injury, and because assuming the wrong thing certainly can be counterproductive to any conversation that might happen after that. That's a very hedgy answer, and I'm sorry.
The only thing I'd add to that is sometimes you need to get some either collateral information or someone to help you, right? So bringing in patients' family members who share your concern but can actually sort of, now you're having a family conversation. Or, with youth violence, for example, there are hospital-based violence intervention programs, or these interrupter programs. And a lot of times the case managers, for example, in those programs are going to be able to approach that patient in a way that hopefully doesn't put you in the hot seat of like not really connecting with them. I think with that,
I think we're out of time. Thank you, everybody.